Hello, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stein. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. Joining me as always, Adam Thacker, who's our Chief Operating Officer of the hospital and pharmacist. We'll be talking and giving you updates on our statistics locally, and also talking a little bit about what's been happening with regards to vaccinations, boosters, update on where we're at with monoclonal antibody therapy regionally, and then talking a little bit about what our hospital statistics have been as well. Starting out with the numbers we always talk about, around 5,900 cases since we started, but the most important numbers are specifically looking at those numbers as it relates to positivity rate. Positivity rates are looking better, but still not fantastic. Our state continues to get lighter in color in terms of our status, and somewhere around 6% or so for all positivity, but still around 26% for unique. And we still know that we're having that community transmission. We still know that that's an active issue. So again, although if we look back 3-4 weeks from where we were, things are absolutely better. But we're still very concerned because those numbers remain high, and although our local numbers are looking better if we look statewide, other counties that kind of have followed behind us are still pretty high in their numbers.
Yeah, and as you mentioned, we're seeing a good trend, but we've also noticed from a hospitalization standpoint, that's somewhat plateaued. So you go 4 weeks ago, our numbers are certainly down, but we saw a dip, and then that now has plateaued. We're running in the teens, 15, 18 patients per day in the hospital, kind of a 50-50 mix right now of general medical versus ICU. Still seeing patients end up on ventilation. We send out every Friday the infograph, and it still is by and large 90-ish%, give or take, unvaccinated that are having complicated illness, severe illness. And we were one of the first regions in those health regions of the state to start to see some decline, and now other areas of the state have seen a little bit of a dip, but kind of the same thing. We're still seeing that hospitals are pretty full as compared to where we were in the early months of the summer, and still putting a lot of pressure on the organizations across the state and getting access to care not only for COVID related, but also everything else that we do on an everyday basis, whether that is elective surgical or chronic disease state management. All of those patients still have access to care, and we're making that happen, but it continues to put pressure on the organization.
Yeah, and so as far as current situation at the hospital, we're still doing all of our elective procedures. Right. Still all diagnostic procedures are open. Visitation has not really changed since we spoke the last time. But it's important to realize that that's always on a bubble of just a few patients one direction or the other. As recently as just a few weeks ago, we talked about having to divert patients to other locations. Thankfully, we have not had to do that as of recently. But it's important to realize that we are trying everything we can in two realms here to help. Number one, getting as much of our population vaccinated as we can, and number two, identifying that population that is at highest risk whenever they develop symptoms, to get them tested and get them treated with monoclonal antibody. So if we look over the course of the past few weeks or so, we're averaging somewhere around 100 or so administrations of the monoclonal antibody, and that's been running a little thin from time to time. Right. But I think statistics recently, allocation sort of helped us a little bit and hurt us in a few ways, but thankfully we have not run out of that recently.
Yeah, it's been somewhat of a rocky transition as some of the federal allocation to state allocation has changed, but we've been able to ebb and flow with that. On kind of the good news front of monoclonal antibody is there's now a third monoclonal antibody agent that is available. It's called Sotrovamab. So we have the region COV, BAM combo, and now Sotrovamab. So we really have three options, and I think what's important for patients to understand is, like we talk about every week, it starts with a positive test, seeing a provider, being assessed for risk, but then once you are identified, you would be a candidate for this. What we've seen great statistics that really would help is that the allocation that comes to us from the state is for monoclonal antibody treatments. We don't get to pick Region Cove or BAM combo. We get what's available and sent to us. And so sometimes the administration of those treatments may be sub-Q. It's 4 subcutaneous shots that are given. in different locations. And then the other option is IV infusion. So just for the public out there coming in for monoclonal antibody treatment, just don't have an expectation of, oh, I'm getting 4 quick injections, because what we have available may be a IV infusion, and that is just based off of FDA approval and formulation of the monoclonal antibody for how it can be administered. The efficacy and benefit that we've seen out of those has really not been different from one administration route versus the other. It's just a mechanism by how we can give the treatment.
Right, and as you led off with, the important thing is really identifying individuals that are candidates as early as possible. As we were running a little thinner, we were having to kind of be very cautious about how we administered that and who that was given to. Because our supply is looking better now, it's still just very important to realize that anybody that has comorbid conditions, specifically anything that gives you an abnormal immune system, we want those people to be top of the list. We also want anybody that is over age 65, obesity, diabetes, chronic kidney disease, cancer therapies, any of those types of things, including chronic lung disease, are high on the list to identify those patients early, get them tested, get them plugged into the system. And we like those patients to be seen, primarily because we want to know just how sick they are, because there's a breaking point at which if you are so sick that you need to be in the hospital or your oxygen level is below normal limits, you're really not a candidate for the monoclonal antibody. So we want those patients to be seen and evaluated by a provider to determine just what the level of their illness is, and hopefully to be identified early in the course. We're still trying to do that within the first 7 days of the illness. People seem to respond the best when we get them on day 2, 3, 4, 5. When we get up into 7+ days or 10+ days, the efficacy is just not as good as what we would hope it would be.
Sure. Earliest in the disease progression is important. And then, we've been pretty fortunate in our community that the pediatric adolescent population that's been affected by COVID has been minimal compared to others. We've certainly have seen some cases of some pretty sick kids, but monoclonal antibody, 12 years of age and older. And so if you have those adolescents, teens, that type 1 diabetics have some immunocompromising disease health issues that they're dealing with, they would certainly be eligible for that. And again, getting tested, getting with the provider, helping to direct that care is really where it starts at, which is our convenient care sites, our medical center of Vincennes. We have online scheduling. We have call-in availability. I think we've done really a great job, those groups, in getting patients in. That transition from kind of the just show up to call ahead, schedule an appointment, go online, book an appointment, has really went smoothly, and it's helped to balance out kind of the workflow on a 8-hour, 10-hour basis. And we don't have people waiting as long, but we're still getting 130 to 150 people tested every single day.
Yeah, which is tremendous compared with what the normal volumes would be. Right. Our educators have done a fantastic job, as have been the administrators, have been doing a great job to keep kids in school and make sure that they are protected as far as masking, but we would still encourage those people to go get vaccinations. Right. Because one of the single best things that we see across all age populations is to get that vaccination and reduce the risk of severe infection. That brings us to something that has changed a lot in terms of identifying risk populations, and that's the pregnant population. I have questions every day from individuals who are pregnant, individuals considering getting pregnant, about what they should do about vaccination. And something that has been identified across the nation, across the world, and now has become a big point with the CDC, is to identify the pregnant population as a hugely at-risk population because of abnormal immune system, different physiology because of decreased ventilation with the lungs. And in states in the United States where we have seen a population that has a lower vaccination rate, the ICUs are unfortunately seeing an increase in the number of pregnant individuals admitted to ICUs, ventilated, who lose their pregnancies or have to deliver early. And so this is an area that we really want to focus on, and making sure people understand that not only is it safe to receive during pregnancy or when you're in kind of a preconceptual phase, but make sure that you understand that it's now become one of the most prominent areas that we really want to push.
Yeah, and there's no gray area in this. ACOG, maternal fetal medicine, those are the medical experts in that field, and they have put out that joint statement that we've mentioned before, and it doesn't say should consider vaccination or talk to your provider. It flat out says pregnant women, breastfeeding women, need to get vaccinated. And it's because of not only risk to themselves, but risk to their unborn baby, or if they're breastfeeding a new infant, and certainly, as you mentioned. And I think one thing that is important to notice is this is not a nuance to COVID.
Right.
Severe respiratory illness in the pregnant population is well known, well documented to create at-risk scenarios, because have a baby, there's putting more pressure on lungs, airway, and it just, your immune system is obviously going through a ton of changes. So there's just increased risk from any type of infection to a pregnant mother, and COVID certainly is following that exact same viral respiratory illness path, and is putting mom and baby at significant risk.
And one of the benefits, I had two women who had recently delivered who asked questions today, and one of the benefits is if you have been vaccinated, you continue to pass those antibodies on through breastfeeding, which is very important. That population, that newborn and neonatal population, obviously is not a candidate for vaccines, and so that natural immunity that's going to be passed on from mom to baby through breast milk is very beneficial. And so I encourage both of them that one of them had actually had COVID and one of them had been vaccinated, but they're actually passing that immunity on to their newborn, and then that continues to provide that protection. No different than when we talk about everything else through our respiratory season. Us adults, the illnesses that we've had in the past, and the female population being able to pass that on through breastfeeding is tremendously beneficial as we go into what our normal cold and flu season would be with the addition of COVID. Obviously, the questions we touched on a little bit last week, I'd like to go over again, which is the boosters. So
Sure.
I get this question multiple times every day, is I understand my candidate for a booster. Should I rush out and get a booster? And my first advice to everybody is, first of all, we want to get everybody vaccinated that we can get vaccinated. Right. So priority number one is to get as many people vaccinated as we can. But there are people that are already candidates for boosters now.
Yeah, absolutely. Vaccination first. As we look at that unvaccinated population, we really need to move in that direction. But the great news from our country's standpoint, and certainly in our state, is that we have ample vaccine, that there is no choosing of should we focus on one versus the other. We have enough vaccine to really say if you're eligible for a booster or if you're unvaccinated, you can get vaccinated really that day. So for the booster population, over 65, so kind of that age-based criteria is that should get vaccinated. And then anyone 50 to 64 with underlying medical conditions, those populations we talk about, from monoclonal antibody being at risk for admission, chronic diseases, diabetes, hypertension, high cholesterol, any lung, heart, health issues that they've been dealing with or certainly taking medication for, they should get vaccinated with a booster shot. And this is for Pfizer, just as clarification. If you were originally vaccinated with Pfizer, the booster is approved for Pfizer. Our Moderna and Johnson & Johnson booster information still yet to come. We anticipate that, down the road. And then you start to drop down to a couple of different groups, and that is that 18 to 49 with medical conditions. That's more of a may get vaccinated. So you're eligible, but that's probably a conversation with your physician and stating, what are your risks? Are there additional risks? Do you have workplace exposure risk? Are you around within your family circle or friend circle? Are you around other immunocompromised individuals to where, it could be, because this is not just about the risk to me, it's also, the risk to others. And then the third group is occupational risk. So 18 to 64, occupational risk, healthcare workers, teachers, frontline employees, grocery workers, gas station attendants that are interacting with large amounts of people coming and going are all in that may get vaccinated. And again, that kind of ebbs and flows between may and should, depending on really the risk of how that applies and what the occupational risk is, because working in the healthcare setting, taking direct care of patients who are vulnerable, immunocompromised, versus working in a grocery store where there's contact, but a lot of healthy individuals and they're coming and going, two different elements of risk.
Certainly, and just as Adam said, looking at what your exposure is. If you're in the healthcare field, if you're in the police force, if you're in conditions where you're around people where you will have greater contact, certainly that's more important. Many people serve the public and many people are in those roles, but it's important to look at what that risk is. Certainly the 6-month span has passed for a lot of the people that initially got vaccinated looking in December, January, February, which was when the biggest push was. And that population that kind of naturally floats to the surface does so because in Indiana we stratified our population to get vaccinated based on age first. And so that population is already kind of ready to get boosted. As far as kind of where we go from here, a lot of people are curious what the world is seeing statistically and then what we anticipate is going to happen. When we look at that graph over the course of the past year or so, obviously we had our big spike last year, then we had our most recent spike with Delta. We have seen an up and then a decline, and we're just on the first part of the decline of that curve. But when we look at that globally as to what has happened, we see that then goes back down. So I think the question on all of our minds is, what is to come?
Yeah, and time will tell to see exactly how accurate forecasting is. But there's anticipation as we enter the winter months. Things move more indoors. There's more risk of transmission of illness. That there is, in all likelihood, expected to be another uptick, another surge, if you will, another wave. Kind of hear those words used interchangeably from a COVID standpoint. Now, there are variables that impact that to a great degree. Vaccination rates continue to climb. That is going to have an impact. I mean, when you look at end of last year, going into the beginning of this year, we were hitting a surge. Vaccination and monoclonal antibody treatment came into effect, and we really saw that drop off. And then variants emerged. We started to see more transmissible Delta. We see another COVID surge, and the push for vaccination really drove up. And along with people, I think, becoming more cautious again, because as is human nature, we start to feel better about things. We start to get a little bit more relaxed. Try to return to pre-pandemic of no mask, and we start to think that headache is just a headache and those allergy symptoms are just allergy symptoms, but then we get a few weeks into it and figure out that it's COVID for everybody. So we'll in all likelihood see some uptick again as we enter the winter months, but certainly the things that are on our side is the vaccination rates going up. We have much better treatment than we did 19 months ago when this all started, when we didn't really have any idea how to treat it. So I feel like that's in our favor as we move forward.
And the other thing is testing is readily available.
Right.
We talk about this every week, that now at our community care clinic, at the site behind MCV, most places, most communities that have community care facilities are testing readily with the antigen test, which is rapid, 15 minutes. And those tests are now also available at the pharmacies. We do get asked questions about the reliability of those tests, and those tests are actually the same tests that we use at our community care facilities and our offices as well. The difference, however, is in how that sample is collected. So we want to make sure that people understand that it is a very operator-dependent process in making sure that sample gets collected properly. Now, thankfully, we don't usually promote the internet for a variety of things, but there are a whole host of good videos on how to appropriately sample your nasopharynx and to make sure that you get a good sampling of that, because if you do that properly, it's just as accurate. The other thing to keep in mind is asymptomatic testing we don't see a lot of utility in. People ask us about that frequently. I got exposed to COVID yesterday, I want to go get tested. And we discourage people from doing that, and we have from the beginning, because it really, there's not much value in it, because there hasn't been enough time for viral replication. There hasn't been enough time for that test to potentially turn positive. So we really encourage people to wait at least 3 to 5 days before they proceed with any type of testing. Now, testing at that point in time can be valuable because it identifies the illness early. But we also realize that there's a number of our population that are not ever going to develop symptoms, catch the illness, and develop their own immunity, which is fantastic. But it's important to realize that the timing of the test and the collection of the test is extremely important, because what we don't want is for people to go get a home test or go to a facility and have testing performed very early on, get a negative test, which gives them a false sense of security that they aren't potentially infectious. And that really takes us back to kind of where we were last year in terms of our quarantine measures and locking people down for 14 days. And really, thankfully, many of the schools have come up with much more reasonable solutions for that, and our kids are staying in school, thankfully. But it's important for all of the rest of us to realize that as it pertains to work and our children and school and activities, that if people have an exposure that's significant, they should still quarantine. And if people have symptoms, don't be around other people. Don't go to school. Every day I get questions in the office where people will say, well, so-and-so had a fever, and we went and got a test, and we did the test, and it was negative, so we sent them back to school. So COVID is not the only thing that we're worried about right now. We have already seen cases of influenza being documented locally. We've certainly seen RSV come around, hand, foot, and mouth has come around. All of our viral gastroenteritis has come around. So we have a whole host of other illnesses, which we are also concerned about and the infectivity of and population health. So yes, COVID has obviously taken center stage for the last year and a half, but it's also important to realize that all the other infectious disease measures that help all of us stay healthy at work and people stay healthy at their work and our children to stay in school should still be followed. So just because you have a negative COVID test and your child has a fever, don't ship them off to school. Wait till this plays out and let's see what it turns out to be.
And that's such a great point, because every week I deal with occurrences of that coming up at our convenient care, and I know you deal with it in our primary care offices, and many of our providers do, of I was exposed, I rush in, get tested, and I'm negative, now I can go back. Well, that's why we put into place criteria that if you're a known exposure, that 3 to 5 days before we will test you, because then we actually can believe the reliability of the test. So when you hear somebody say, I went and got tested, and then I tested 4 days later and I was positive, that first test was bogus, false negative. It wasn't a false negative, the virus wasn't there yet. So we have to wait the appropriate amount of time. And then the second piece, the symptomatology, the symptoms you're having, are the leading indicator. Mm-hmm. If you test negative and you have loss of smell and a headache and allergy type of symptoms, sore throat, runny nose, you test negative, that negative test is not a return to work, return to school card. Right. You have symptoms that are consistent with COVID. And pre-mass availability of testing, that was just considered presumed positive. Right. And there was a reason for that. And so our providers that give you that negative test that then quantify or qualify that by saying you have symptoms, may need to retest in 48 hours. If your symptoms worsen, all of those details. We see a lot of that, that folks that test is, that's all I need. And then, you find out 2 days later you were positive because your symptoms worsen and you get tested. And in those 2 days, the number of people that you can potentially be around and transmit virus to and infect, that is why that we're kind of plateauing at 24% instead of seeing that 20 and 18 and 15, is because of that very phenomenon that we look at that as the get out of jail free card because I have this negative test. I did see that White House announced a $1 billion plan to massively increase availability of home test. And while there's great utility in those that can use the home test and having kind of early identification, I just want to continue to kind of qualify from a medical field standpoint. We don't use home test as diagnostic. Correct. So calling one of our providers and saying, I have a positive COVID test I just did on myself at home, can you order me monoclonal antibody, or, what do I need to do? If you call with that home test positive and say, what do I need to do? The answer is in all likelihood going to be go to convenient care, go to the medical center and get tested by one of our trained professionals that do 100 tests a day and make sure that we do what's called confirmatory testing. So just keep in mind that that's not a medical diagnostic tool. It can really just be used for your home. If by testing I can self-isolate and watch my symptoms, that's fine, but it's not a diagnostic tool.
And that's no different than any other things that we deal with. When people report that they had a high blood pressure that was checked at the pharmacy, or they had a high blood pressure that was checked at a health fair, or they had a high blood pressure that was checked at home, or they did a home cholesterol test or blood sugar test or whatever, we still want to confirm those test results, because obviously it has a significant impact on that individual and then any individuals that they're exposed to. So don't be surprised if we repeat those tests, because we want to confirm the positive or confirm the negative one way or the other. One thing that will also come up, not terribly frequently, but I think is a curiosity to individuals, is test negative prior to X event. I'm going to travel, I'm going to have surgery at another facility, I'm going to go to camp, I'm going to go to this event, and I need to have a negative test. One of the most important things to determine with that is what type of test qualifies for what's being asked. I've had a number of individuals who have traveled overseas, primarily to Asia. Those areas, those countries primarily are requiring a PCR negative test. I've had a couple of individuals who've recently traveled to Canada, some that have traveled to Mexico, some that have traveled to the Caribbean. They were qualified for travel based on an antigen test. And so it's important to ask the person who is telling you need to have that testing performed ahead of time a couple of things. What type of test is required, and what is the timeline that is required prior to the event? So if you're going to have a knee scope performed and you need to have a negative test prior to that, typically they will tell you need to have a PCR test done 3 days prior to that to make sure that you're not ill or not a carrier for that. And there's a variety of reasons for that, not the least of which is to make sure that during the time that you're about to have surgery, that you're not just about to develop COVID and have respiratory difficulty with that. The risks also obviously in the postoperative period are important as well. So those questions, when they do come up, obviously we have the rapid antigen test that's available here. We have the PCR test, which has a variability on timeline anywhere from 2 days to X days, 7 days plus.
Yeah, and actually one of the positives as we talk about testing and having more supplies is that really this last week we've moved towards having enough supplies that we are able to run those non-medical tests for travel and such in-house and turn that around. And when we say in-house, we're turning that around by the next day.
Yep.
Send-off is 2 days. Now we're starting to be able to do that. Now that's always dependent on the supplies that we have. So it's not always a guarantee. As Dr. Stein mentioned, if you have those events coming up, calling ahead and saying, per my scheduled surgery or per my trip to X, international location, I have to be tested in this time frame. What do I need to do? I get that call quite a bit, and we work through, you just work through the timeline backwards as to, okay, here's where you need to be, when you need to be tested. The test sites are still the same. Our convenient care sites, our medical center can provide that testing. We'll need to know, PCR versus antigen. Most are requiring PCR. And the other thing is that is non-medical. So while federal government has been wonderful about covering cost of supplies and vaccinations, and it's kept the burden low to individuals, non-medical testing is not billed through insurance. It's not covered by CARES Act, so it does carry with it a cash charge for that. And that's typical of anywhere that you would go to get that test.
Sure. Any other things before we go to phones today?
I think the only other thing I would mention is, each week we tend to have the questions on the next vaccination group, ages 5 to 11. Most recent update is still really the same update, but end of October, early November, we do expect that group will have emergency use authorization and start to be able to provide vaccination to that population.
Okay. Tiffany and Mallory on special assignment, I think, in Bicknell this week, so we have Clint with us. Clint, what do you got for us this week?
Yeah, we just have a couple questions here. So first, how is the vaccination of GSH employees so far?
It's been going very well, as we've talked about in past weeks. In July, we announced our move towards mandatory vaccination of COVID vaccine, very similar to influenza vaccination and other conditions of employment. By that date, we were about 47-48%, which is actually where Knox County sits at today, and is also equivalent to where Indiana sits at, but we are at 73%. So 73% of our employees have had at least one shot vaccine, and then we'll complete the cycle, obviously, with shot 2 of Pfizer, or if they're getting vaccinated with Johnson & Johnson, the one shot, but 73%. So really, really happy to see where that has moved. It's over 1,300 employees have been vaccinated, and just great results as that continues to go up week by week.
And one of the things I think that people have been asking me recently, because they're getting into timeline issues with vaccination as it pertains to their employment, is what their options are. And really, it's any vaccination. And if there's a timeline issue, obviously the J&J vaccine is a single shot vaccine, and it's one and you're done. The Moderna and Pfizer are a two-shot series with roughly about 3 weeks in between those vaccinations. So if timeline becomes an issue, that's a potential option for you in terms of getting vaccinated in a more rapid manner. And the numbers look good with any of the vaccines. When we talk about them, we all received Pfizer vaccine because at the time that was the super cold refrigeration, 0 Kelvin, and having that in-house is what we all use. Moderna was the one that was in most of the health departments, but all of the numbers look good. And so whenever the question comes up of vaccine and which one I would choose, it's which one that you have available, whichever one you're most comfortable with, but get vaccinated. And there's really no question when people come to me with what their concerns are with regards to the rapidity of the vaccine, the thing that we go back to is simply the massive number of individuals who have been vaccinated. Never before in history has there been such an incredible number and incredible tracking of what the vaccine success has been, and the statistics on reducing severe illness, hospitalization, ICU admissions, and intubation. So I have no hesitancy. Obviously, we all got vaccinated, and we're encouraging our friends, family, and employees to get vaccinated. But when that timeline comes up, that's a potential option also.
And that remains the key when we talk about the statistics, because you see so much put out there about, well, this is 90%, this is 70%. And when we go back to vaccines were created to prevent severe illness, hospitalization, and death, all three vaccines perform at the top of any vaccines we've ever seen created in our lifetimes. And so that's really promising in what we're seeing.
Is the health department the only place to get your third vaccine?
No, you can still go to ourshot.in.gov, and there are pharmacies within the community, and then certainly surrounding counties. Actually, there are locations in every single county in the state of Indiana to get vaccinated. Some are health departments, some are pharmacies. Most hospitals that were in that vaccinating the community role have moved back to just taking care of their employees and their patients at the hospital, such as what Good Samaritan is doing. But health department is an option, and then certainly the pharmacies through that website, you can identify those. Walmart, CVS, Walgreens are all providing that.
If you're vaccinated, had COVID, and received the infusion, how safe should you feel, and should you get the booster, or do you already have enough antibodies?
So it's a great question, and this gets a little convoluted when people have had the illness, got vaccinated, had the illness. Specifically with that question, the issue of had the vaccine, got the illness, received monoclonal antibody, we like to see a 90-day time span after the monoclonal antibody, because what has essentially happened with monoclonal antibody is we have given you a synthetic antibody that basically helps to neutralize and deactivate that viral infection, and that hangs around for a while, no different than our own antibodies do. But yes, you are protected, and you are protected not only from your initial vaccine, but also from your own immune system's response to that, and then also from the immunity that you receive from the passive vaccination of the monoclonal antibody. That being said, should you choose to get the booster, you can get the booster at any point after that, but we would prefer it to be after 90 days, just because we, again, want your body's immune system to be ready to go after that and increase your immunity from that point forward. All right. Any other things for this week?
No, I don't believe so.
All right. Thank you all very much for joining us, and we'll be back with you again in a week. Thanks.